Hello and good afternoon, Dr. Mendelson. Maybe before we start, I'll let you introduce yourself to the listeners here.
Hi, I'm David Mendelson. I'm the Vice Chair of Radiology Informatics at the Mount Sinai Health System in New York. I'm also Associate CMIO of the Mount Sinai Doctors Faculty Practice.
So thank you for that introduction. I'm Ariella Shoham. I'm Aidoc's VP of Marketing, and I really appreciate the time you have with me today for a 15-minute fireside chat. The reason that I asked you to join us is you've been an advocate for new technologies and a real innovator and thought leader, and I wanted to hear your thoughts about AI and the adoption of AI specifically within your facility.
Sure. So most of the radiology community has certainly been saturated by opportunities to employ AI technologies. There are many vendors out there, many who have good algorithms. When looking at this, the thing that the radiology department has to do today is find a vendor or a partner who has good algorithms that will fulfill some of your early needs, and at the same time, a vendor whom one believes will survive in what is ultimately going to be a shakeout, and a vendor who gives you good support and shows you they have an eye to the future, because we're really just at the beginning of this right now. Just for transparency, we have worked with a few vendors. One of our main vendors in this case is Aidoc, and obviously you're hosting this interview. And so we've signed an agreement to work with Aidoc at this point in time, but we do have other vendors present as well.
Thank you. So you were talking about the fact that there's going to be a shakeout, and I think we can address that because I agree there are so many AI vendors and it's hard to find a use case that's specifically interesting, I guess, per site, but maybe you can talk a bit to the use case or some of the use cases that you've been using AI for within your department.
So one of the interesting issues with AI, many of these algorithms are quite successful, but they're very focused. And some vendors have one algorithm only. In the case of Aidoc, one of the reasons we decided to pursue a relationship was you had 4 that were already FDA approved, and you had 6 or 7 others that were in the planning process at various stages of development. We've now been using your solutions for about 6 to 7 months at this point in time. The 2 that we're most focused on right now are your pulmonary embolism algorithm and your intracranial hemorrhage algorithm. We've also just started to use the cervical spine fracture algorithm. And what we've learned is that these can be very useful. I'll talk a little bit about how useful and how successful this has been. We all are well aware that to get FDA approval today is a pretty rigid set of requirements and constraints. And many of the algorithms that vendors put out there for customers such as ourselves have a very high sensitivity, but are not particularly specific. So there are many false positives, and that's an issue that has to be dealt with. The other thing we look at when judging whether or not we want to pursue a relationship is the ability to provide an alert when a positive result is found.
Fantastic. It's fantastic. And I heard a few things apart from the assistance in flagging cases, as you mentioned, but also you talked about getting used to using AI, right? So I think also from an audience perspective, we have radiologists who are listening to this. So do you think that this is going to increase adoption rates? The more we talk about it, the more you use it. Do you think radiologists are going to be more inclined to use AI? What are your thoughts?
I do. I think right now AI is an adjunct. So all the talk about replacing radiologists, for the moment, that's a meaningless conversation.
Right.
That's not to say 10 years from now, workflows and the use of algorithms like this will be different. But for the moment, these are very focused algorithms on usually one particular problem, and they just do not interpret an entire exam the way radiologists do. So they're certainly at the moment not a threat. I think the next step in evolution here will be algorithms that look at more than one feature and function. And so something that can look at an entire chest and not just evaluate for a lung nodule or a pneumonia, but both, and other secondary findings as well. I do think that in the near future, certain kinds of algorithms, if they begin to approach 4 or 5 nines in both sensitivity and specificity, will be game changers in how we provide our interpretation. So if you look at something like CT nodule screening, today, I believe the proper way to do that is with the radiologist reading it first independently of a CAD program or a deep learning program, which might do better than traditional CAD programs. But nonetheless, those are not accurate enough to go first. But what if we had a program that was in fact 5/9 sensitive and specific? That changes my role as a radiologist. I could certainly screen more patients, but my role would really be to look for other findings that this dedicated algorithm was not finding. But we're not there yet.
But I think you're right. That's a combination, right, of the man and the machine. It's not a man against a machine. I think it's a man with a machine versus man without. And I think that's where that's going to go, right? Like planes today, there are autopilots, but there's still a pilot. And so I think that would be the same. It's like an augmented radiologist who's using a tool to make sure that sort of your combined powers work together, I guess. That's sort of maybe how I would see it. Maybe from a marketing perspective, that's how I would see it. I just wanted to touch on something that you said, and you mentioned CAD, and I guess I want to touch to user experience and how this integrates into the actual workflow of how RADs work. Maybe you'd like to say a bit about that, because I think that would contribute to adoption as well. Do you agree?
Yes, the workflow turned out to be extremely important. And there's always been a lot of resistance to CAD, not because it's not useful, but because it really added significant time to one's workday, especially as our volumes have increased. Mm-hmm. So CAD for mammography, CAD for CT of the lung, for nodule detection are two things that come to mind fairly quickly. So I think the vendors who succeed at this will have also looked at better ways to integrate alerts and letting us know that the results are available. So first and foremost is just embedding an image in PACS, and most people are on their way to doing that with secondary captures. But for instance, in your case, there's a widget that lives on our PACS system that is inconspicuous enough to not interfere with reading, but on the other hand, conspicuous enough so that every time you have an alert, we know it's there and we know to open it and take a look. That's a good first step. The real answer here will be true integration into PACS work lists with proper flags. We happen to be a Centricity PACS user, that's a GE product, and we are about to embark on an early beta relationship with a new kind of work list in their environment, which will hopefully integrate Aidoc, and I've been told by both vendors that they are working together. And we're going to see more and more of this. So it's going to be important in the PACS world to understand how to put a sensible stratification system, statusing exams, so not just stats, but AI positives. And it may even get more granular and refined than that over time. But that's going to be very important to gaining radiologist acceptance. There is a change management issue here for thousands of radiologists who have to accept this and integrate it into their daily work.
So you were talking about usage and sort of comparing this to CAD, and I guess maybe one of the questions is within your department and your facility, how is the acceptance of new technologies been? So how is the adoption or acceptance, I guess, going?
In general, we find that the younger generations of radiologists, the trainees, are most easily adopted to new technology introduction. It's kind of part of the way, especially the residents and fellows, the way they've been raised. They've been raised with a cell phone as being a natural extension of their arm. So to them, it's quite natural when someone introduces a new technology, they quickly volunteer to try it and use it. And they're quick to criticize it, by the way, if they see imperfections within it. There are older radiologists who easily adopt, and then there are many who have just worked one way for 20, 30 years and find it a little more difficult. We had the interesting experience at Mount Sinai when voice recognition was being first introduced. Our earliest adopter was a 90-year-old radiologist who wanted to keep on working, and he embraced it almost immediately. he became the poster boy, in quotes, if you will, for the vendor who was implementing it at that point in time.
Amazing.
Change can be difficult, but I do think the younger generations here, and that's true, by the way, in the EMR world, which I have some exposure to through my other hat, is residents, fellows, trainees are much more expecting to see new technologies introduced, and therefore are more easily embrace such.
And maybe a run off to that, maybe a bit about the practicality, and who would you bring to the table to, I mean, again, you're at the top of that decision-making funnel, I guess. So do you think that's a decision that's made top down? So if you're an advocate of AI, then everyone's going to use it, or do you think this is something that you have to bring in additional people to make that decision?
You know, it's interesting. We run a variety of IT forums within the radiology department because there's so much enthusiasm about this. So ideas through those forums can come from anywhere, including often the trainees. With that said, once there's an idea floated out there, it's usually first put into slightly more experienced hands. So in my role as a vice chair, but our chairman has been actively engaged. As I said, we're a multi-hospital system, so we have site chairs who are very experienced with practice management. We get them all involved early on. Usually we will then champion a pilot program, which is planned with all these people, and execute on that and gently broaden the pilot program. So usually the way we've introduced new technology is post-pilot, if we've decided to acquire something, is to find a few early adopters first for the first few weeks, have a few lessons learned, and then quickly broaden this. And one of the things we find is don't tell everybody to try to learn the entire function and application the first day. Find the things that are most useful, the highlights of it, use those for a few days, and then build your repertoire because there's often other functionality present.
Interesting. So maybe I'll leave this open. So given the audience, and we covered deployment, we covered some usage examples, is there anything that we haven't covered that you think could be interesting, or any takeaways?
I think an extension of what we're discussing is things like the use in stroke teams, and we're very interested in pulmonary embolism response teams. Any of the domains where response time is very important. So it's important to get a quick result out of the algorithm, out of the AI solution, but then to deploy that result through a variety of alert functions to the proper people, starting with the radiologist, but in the case of many of these other teams, it needs to go to a neurologist, a neurosurgeon, an interventional radiologist, if you will, an interventional cardiologist, depending on how PEs are handled in any institution. So these are all secondary things, not quite as exciting perhaps as the diagnostic utility of the AI algorithms, but quite important to now consider. And again, these will be things that make the distinctions between vendors, the ones who can address these things or work to address them, because nobody has all these answers today.
Yep.
Some of you have some level of maturity in trying to address these things. And again, it makes it dynamic. Today's solution may be totally replaced by the same vendor 6 months from now. So it is an exciting domain, and ultimately should bring good things to patient care.
Agreed. Thank you. So thank you so much, Dr. Mendelson. Anything else that we haven't addressed, we can sort of...
No, I think we've covered things that the radiology community will certainly be interested in, just that they should be aware that this is going on in their brethren and other specialties as well. So we're a very exciting domain. We lend ourselves to early adoption of digital technologies, but the others are trying to catch us, and for good reasons.
Thank you so much. It's been a pleasure, Dr. Mendelson. Have a great afternoon.
A pleasure here as well. Thank you.
Bye-bye.